This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Lara, Research Fellow. Today we're looking at a fascinating new study from Acta Neurochirurgica, published in 2026, titled Microsurgical Anatomy of the Anterior Inferior Cerebellar Artery, Systematic Review with Meta-Analysis.
This is a vital topic, Ilara. The anterior inferior cerebellar artery, or AICA, is arguably the most significant vessel of the cerebellopontine angle, or CPA. For any resident or attending working in the posterior fossa, the AICA is both a landmark and a potential landmine. This meta-analysis pooled data from 64 studies covering over 15,000 arteries. That's a massive sample size for microsurgical anatomy.
It really is. And the study starts by reinforcing the standard anatomy before diving into the variations. According to their results, the AICA originated from the basilar artery in 90.1% of the general population. Specifically, it usually comes off the middle portion of the BA, the lateral section.
Right. It then runs posterior-laterally, ventral to the pons in the prepontine cistern, and enters the CPA. One thing that residents often overlook during dissection is the bifurcation. The paper notes that the main trunk typically bifurcates into superior, or caudal, and inferior, or rostral trunks. This usually happens right at the level where the facial, vestibulocochlear nerves, CN7 and 8, exit.
The study also details the supply territory, which is critical for understanding the deficits we see if a lesion occurs. The AICA supplies the anterior-inferior surface of the cerebellum, the flocculus, the lower third of the lateral pontine area, and sometimes the middle or superior parts of the medulla. Interestingly, it also mentions the supply to the choroid plexus of the lateral ventricles.
That supply to the brainstem and cerebellum explains why iatrogenic lesions, whether ischemic or hemorrhagic, are so devastating. The authors list vertigo, dizziness, facial paresis, ataxia, and nystagmus as primary symptoms. In the worst cases, it can lead to death.
Speaking of iatrogenic risk, let's talk about the relationships with the cranial nerves. This is where the microsurgery gets really tight. The meta-analysis found that the AICA was in contact with the abducens nerve, CN6, in up to 82.2% of the general population. That is a much higher frequency than many might expect.
That's a key point for residents during a retrosigmoid approach. If you're looking for the abducens, you're almost certainly going to find the AICA right there with it. But the real action is at the 7-8 complex. What did the meta-analysis show regarding that relationship?
This was one of their most significant findings. They found that the AICA was located between the facial nerve, CN7, and the vestibulocochlear nerve, CN8, in 60.6% of cases. It basically sandwiches itself between the two nerves of the complex.
And that brings us to the clinical heart of this paper: compression syndromes and AICA loops. We know that the concentration of nerves in the CPA means that any vascular formation, like a loop, can cause major issues. The study mentions tinnitus, hearing loss, and hemifacial spasm as classic symptoms.
Exactly. And the prevalence of these AICA loops is quite high, 58.3% in the general population. But the study found some incredible geographic variation. In the South Korean population, the prevalence of AICA loops went as high as 77.1%. Conversely, in the Turkish population, it was only 18.0%.
That is a staggering difference. It suggests that a neurosurgeon's anatomical expectation might need to shift depending on the patient population they serve. If you're performing a microvascular decompression, or MVD, to relieve those symptoms, knowing that a loop is more of a rule than an exception in certain populations changes your surgical planning.
They also emphasized how these loops and other vascular variations can complicate tumor resections in the CPA. When a tumor distorts the normal anatomy, these common variants are even harder to identify, which increases the risk of those iatrogenic lesions we discussed earlier.
I also noticed they touched on bypass procedures, specifically the occipital artery to AICA bypass.
Yes, they mentioned that in such complex procedures, the correct identification of vessels is crucial, but often complicated by the many different subtypes and branching patterns. The study found a unilateral branching pattern in 85.5% of the population.
It's those variations that make the AICA so fascinating, as you put it. If you go in expecting a single, clean trunk and find a complex branching pattern or a loop tucked between the 7 and 8 nerves, you have to be prepared to adapt.
The takeaway for the residents listening is that the AICA isn't just a vessel in the neighborhood. It is intricately tied to the CN6, 7, and 8, with an 82% contact with the abducens and a 60% chance of being between the facial and vestibulocochlear nerves. You should essentially expect contact in every case.
Absolutely.
The study concludes by reminding us that these variations aren't just anatomical curiosities. They produce real neurological symptoms and increase the risk of injury during surgery. Whether you're doing an MVD, a tumor resection, or a bypass, you need standardized knowledge of these common types.
It's a great reminder that normal anatomy is often a spectrum of variations.
Well said. This meta-analysis in Acta Neurochirurgica provides a much-needed baseline for that spectrum. Thank you for joining us on the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Alara. We'll see you in the next episode.